Hello, everybody, and welcome back to another webinar all about Parkinson's disease psychosis. I am here with Dr. Wint today, and he is going to be answering a bunch of the questions that you all emailed me and that you chatted during the last webinar that we didn't have a chance to answer. So, hi, Dr. Wint. Thank you so much for being here.
Hi, it's my pleasure. Thank you for the invitation.
Absolutely. So just a little bit of housekeeping. If you, I did get a lot of questions sent in before. If you already emailed me your question, you don't have to send it to me again on chat because I do have it. If you haven't sent it to me and you have another question that comes up during this session, the little icon at the bottom of your screen that says chat, you can just click that. It'll pop open. On the right-hand side, you'll probably see a little blue button. And you can either choose to send the question just to me. It'll probably say panelists, and only Dr. Wint and I will be able to see it. Or if you want everybody to be able to see the question, which is great sometimes because a lot of people have the same questions, then you can just choose all panelists and attendees and everybody will see your question. I will send out the recording just like we did the other video. So if you have to hop off early, the recording will be available to you. I think we'll probably get it to you either late, maybe by Friday, but early next week for sure. So that won't be an issue. I'm just going to do a quick introduction to get you to know Dr. Wint a little bit better and see why he's here with us today. And then we're going to jump into questions. So Dr. Dylan Wint joined Cleveland Clinic Lou Rouveau Center for Brain Health in May of 2010. His clinical interest is optimizing the diagnosis and management of neurodegenerative disorders. Dr. Wint earned his undergraduate and medical degrees at Stanford University and the University of Miami. He completed simultaneous residencies in neurology and psychiatry at the University of Florida and fellowships in deep brain stimulation and integrative neuroimaging at University of Florida and the National Institutes of Health. So he has a wealth of knowledge and experience on this topic, and we're really excited to have him here today. So let's jump in. I think the question that I get the most often is, are hallucinations always a side effect of medication, or is it a sign of Parkinson's progressing, or both?
Yeah, that's a great question. So the first part, hallucinations were seen in Parkinson's disease before the advent of levodopa, which was the first effective treatment for Parkinson's. So we do believe that hallucinations, or the tendency towards hallucinations or susceptibility to hallucinations is part of Parkinson's disease itself. However, it's quite clear that medications do increase the risk for hallucinations, and that's the biggest controllable risk factor for hallucinations. In particular, the dopamine agonists, so those would be pramipexole, ropinirole, and rotigotine, are the biggest offenders in terms of risk for producing hallucinations.
And so if somebody is taking one of those drugs, do hallucinations tend to show up pretty early on because they're just susceptible to hallucinations and the drug is interacting with them? Or is it that they could be taking those drugs for many, many years before they see a hallucination due to the fact that at that point their Parkinson's is progressing more?
Another great question. You can certainly be taking a medicine for years and get hallucinations on that same medicine as Parkinson's disease progresses. So other risk factors for getting hallucinations include duration of disease. So the longer you've had Parkinson's disease, the more likely you are to get hallucinations. Folks who are older tend to get hallucinations at a higher rate. If you have a visual or sleep problem, you're also more likely to get hallucinations. So these are all things that have the potential to change, right? We get older while we have Parkinson's, we have a longer duration of disease, we may develop vision or sleep problems. And those things can also contribute to the likelihood of hallucinations.
Okay, so you bring up the sleep issue. That's a common question too. Can a sleep issue be considered a hallucination, or is that totally separate?
So there has been sort of varied evidence on whether very vivid dreams are associated with the production of hallucinations, maybe a very early stage of hallucinations. My sense of it is, and I think most people who work in Parkinson's would agree, that hallucinations tend to start in situations that make us more susceptible. So in addition to the things I mentioned before, we also tend to get more hallucinations when there's a mild metabolic disturbance, dehydration, urinary tract infection, or when the environment is more ambiguous. So hallucinations will tend to start off occurring at night and then will progress so that they're occurring at more times during the day. So there's this relationship between vivid nightmares and hallucinations that's, I think, partially supported. There is more solid data for a relationship between REM behavior disorder, which is when people act out their dreams. They're asleep, but they're moving as if they're behaving based on the dream. And general sleep disorders, obstructive sleep apnea, insomnia. There's a clear relationship between the presence of those sleep disorders and the presence of hallucinations. Some people think that hallucinations may be similar to REM behavior disorder in that it's a disruption of the brain's ability to keep dreams and sleep states in their correct domain and keep movement and waking states in their correct domain. Okay. There seems to be a disruption of this in Parkinson's disease, maybe why people get so drowsy. Again, it may be why people hallucinate. It may be why they have REM behavior disorder.
Okay, great. Are there stages to the hallucinatory effect? So let's say you start off, and a lot of people start off and their hallucinations look a certain way. And then as time progresses, they get more aggressive or something like that.
Yeah, I would say almost invariably there is a progression of the hallucinations, almost like the progression of Parkinson's disease. Initially, we see things that are mild or maybe even not clearly abnormal. So these can include things like what's called hypnagogic or hypnopompic hallucinations. These are normal phenomena that when you're falling asleep, you might hear a voice talking to you or something like that, usually brief, but it does tend to happen more in people with Parkinson's disease, and it does tend to presage hallucinations later on. People can also have phenomena that are not quite hallucinations, but are abnormal sensory experiences. So this includes a passage phenomenon where someone feels like something is going by them, often out of the corner of the eye, or a hallucination where someone actually sees something out of the corner of their eye. When they turn, it's not there. So it's not well formed and it's not stable like in the typical hallucinations, but it may be an early stage. And then in a lot of my patients, I've seen hallucinations progress from, say a small animal passing by or something like that, to then a person, to then a group of people. So there is a sense that the hallucinations do tend to worsen, become more vivid, more complex over time.
Is there any relationship to insight in terms of the advancement of hallucinations? So if those early hallucinations, you might just have the sense, you have more insight then than you might later down the road when they're becoming much more complex?
That's correct. Typically, as the hallucinations become more complex and more persistent, there tends to be a decreasing level of insight. Usually insight is retained at the very beginning, but it gets lost later on. And sometimes sometimes you can get what we call superficial insight. In the doctor's office, or maybe after a hallucination is over, the patient will say, oh yes, I know that those aren't real. But while they're in the hallucination, they'll do things, like offer the person tea or walk over and try to talk to them, even though later on they'll say, oh, I know that I hallucinate and those things aren't real. So there is a compelling nature to having a visual stimulus in front of you. Human beings are very, very tuned to respond to visual stimuli. And even when that stimulus is not there, if we know we shouldn't respond to it or we should avoid responding to it, sometimes when it does show up, we cannot help ourselves.
Right. So that brings up a question. I'm imagining that there's somebody in your office and maybe they had a hallucination in your office, or they had it at home and now they're there and they are saying, well, I know that that was not that wasn't real. I was having a hallucination. Are those people, in your experience, do they tend to be scared? Is it, okay, no big deal, I know that happened? Like, I just would imagine it's a pretty frustrating and scary process. So what do you
Yes.
see?
My experience, although frightening hallucinations can occur, most of the hallucinations tend not to be frankly frightening. They may be annoying or surprising. And again, the person's behavior may be influenced by them. I've had patients who, for example, won't go into the bathroom because they see that somebody's there, or they're upset because someone's in the bed with their spouse. Um, so they do tend to be frustrating, annoying, maybe even angering. I don't have a ton of patients where they are actually scary or frightening, but don't let that mean that it can't happen. It just is the minority of cases.
Okay, great. Is there any connection between dyskinesia and hallucinations? Or is it because they're having the medication is causing it, and that medication also causes hallucinations?
Yeah, another great question. So the worse the motor disability, the higher the likelihood of hallucinations. And the worse the motor disability, the higher the likelihood of dyskinesias. So whether dyskinesias are directly related to hallucinations, or whether both dyskinesias and hallucinations are a product of worsening motor disability, is pretty hard to tease out. But clearly people who have dyskinesias are more likely to have hallucinations and vice versa. But that may simply be because they tend to also be people who have had the disease longer, who are older, who are on more medication, and who have worse motor disability.
Got it. Okay, great. I know that you have definitely a lot of experience in DBS. Does DBS have any effect on hallucinations? Does it change the frequency of hallucinations? Does it eliminate them completely?
It appears that the effect of DBS on hallucinations is indirect. When people get DBS, typically that can lower their medication burden. And so with less medication, you're taking away one of the major risk factors for having hallucinations.
Right. One of the questions that people ask a lot is, if I have a hallucination, is it always going to indicate that it's going to get a lot worse? And are hallucinations often a big factor in people having to be in long-term care facilities because people just can't, care partners can't deal with it after a while?
So hallucinations typically are worse when they end than when they start.
Mm-hmm.
I wouldn't want you to take that to mean, though, that if you have hallucinations now, that I know that next year they will be worse. I don't know if it's really true of most of my patients, but certainly some of my patients, they get to a point where the hallucinations are the same old thing year after year.
That would
But
be
usually, I'm
relieving
sorry.
to people to
Yes,
hear.
yes. Uh, Usually, when hallucinations first start, they're not as bad as they're going to be, but that doesn't mean that every moment of a hallucination, the next time it's going to be worse, or the next year it's going to be worse. As to the nursing home placement, hallucinations can be associated with nursing home placement. Delusions, which are fixed false beliefs, tend to be much higher. There tends to be a much higher association with nursing home placement. However, delusions and hallucinations often run together, but it's typically the delusions that drive the nursing home placement. And again, it's difficult to separate out, at this point, when someone's having severe hallucinations, they're also having severe motor disability. They've had the condition for a longer period of time. And so that all plays in.
Okay. So when it comes to the timing, actually, if we're going to talk about hallucinations and delusions, most of the time we hear that hallucinations, this happened and the person was in a hallucination for a minute or two or less, and then it goes away. What is there a typical time frame that a hallucination lasts? And then also, what about delusions? If we're talking about, those are the things that more often cause people to be in long-term care. Are delusions just, once they get it, they stick with it for a long time? Is that longer than a hallucination?
Yeah, so delusions tend to be more persistent. They are fixed beliefs. Now, sometimes with adjusting medication, we can see a delusion go away. But very often, if you ask carefully, you will find that the patient, although they don't believe that delusion anymore right now, they still believe that whatever they thought happened did happen in the past. It's just, it's over now or whatever. Delusions do not usually sort of appear as fleeting phenomena. Now, someone's response to the delusion may be fleeting. So if someone has a delusion of jealousy, where they think that their partner is cheating on them, they may not be angry about it all day. You know, they may not even show anything for days at a time. That doesn't mean that that belief is not there. Hallucinations do tend to be fleeting, particularly in the beginning, such as those passage hallucinations or hallucinations out of the corner of your eye. As hallucinations progress, they are more persistent, and there are people out there who are essentially hallucinating all the time.
So what do you do as a doctor in terms of trying to adjust meds? Obviously, if you're going to adjust the meds, something else is going to suffer. And when you're working with patients, do they tend to err more on, well, I'd rather have better control of my motor symptoms so I can go about my day and deal with hallucinations, or, you know, get me off of this no matter what. I have to do it because I can't live like that.
It really depends on the degree of suffering and disability. So we absolutely try and adjust medications when someone has developed hallucinations, because the natural history is that they're going to get worse. So even if they're not particularly bothersome or persistent at the moment, we have to think about that in 6 months or a year, in someone where they've just emerged, that they are probably going to be worse. So we try and reduce medicines that are more likely to induce hallucinations. Again, that starts with the dopamine agonists, then anticholinergic medications, such as benztropine, or otherwise known as cogentin. Opioid medications also lower the threshold for hallucinations. Benzodiazepines and other sedatives, so those are things like clonazepam, lorazepam, and then stimulants. Levodopa, of the medicines that are directly used to treat movement problems, it is the one that's least likely to induce hallucinations. So sometimes we'll switch out a dopamine agonist in favor of levodopa.
Okay. What about alcohol? Does that tend to, influence hallucinations? Does it up them? If you just said, I was interested that you said opioids, I would be like, does it calm them down?
You know, I don't have any actual data on that.
Okay.
It's a hard study to do because, you don't want to give a bunch of people alcohol, but I would suspect that an amount of alcohol that's enough to produce even mild intoxication would be likely to lower the threshold for hallucinations. And this is the reason I say that is almost anything that affects brain chemistry and brain operations has a potential to cause hallucinations. I mentioned already dehydration, urinary tract infections, sleep deprivation makes hallucinations more likely. So it would actually be a shock to me if alcohol did not.
Yeah. Okay, great. Let's see. Do hallucinations have any commonality with cognitive decline in people with Parkinson's?
Yes, absolutely. So cognitive decline is another one of the risk factors for developing hallucinations.
Okay. Let's see. Are there any medications that you find effective in treating anxiety and paranoia in atypical Parkinsonism, like PSP or Lewy body?
Yeah, that's a good question. So paranoia, we would consider to be a psychosis symptom, a delusion, the fixed false belief that somebody intends to harm you. And there are medicines that we use to treat hallucinations and delusions in Parkinson's disease. The delusions in Parkinson's disease, as well as other movement disorders, the delusions tend to be a little bit more resistant to treatment than hallucinations. So I'm going to address this mainly in terms of Parkinson's disease and Lewy body disease, because we have the most data on those. Those are more common by far than, say, progressive supranuclear palsy or corticobasal degeneration. So the FDA has approved a medicine called pimavansarin. The brand name is Nuplazid, for treating hallucinations and delusions in the setting of Parkinson's disease. It is pretty well tolerated. The most common side effect at about 8% of people is swelling in the legs. And that was just a little bit higher than placebo. So it's pretty well tolerated, and it was found to be effective in the pivotal study that led to its approval by the FDA. Another drug that is effective is clozapine, brand name Clozaril. Actually, it has a lot of brand names because it's generic now. So this is a medicine that actually, I think, was developed in the 1950s for treating schizophrenia and other psychosis conditions. It is useful in Parkinson's disease because it does not block dopamine receptors to any great degree. And most antipsychotics, medicines that treat hallucinations and delusions, exert their effect through blocking dopamine. So it doesn't block dopamine. It is effective. It's been shown in numerous studies to be effective. However, it's a little bit difficult to use because it can drop the white blood cell count. So when you take it initially, you have to get blood draws every week for 3 months, I think it is. Then blood draws every 2 weeks for another 3 months, then monthly blood draws, and so on. And it also can cause constipation, drooling, drowsiness, which are problems that a lot of folks with Parkinson's already have. And then the third medicine that is commonly used is quetiapine or Seroquel. A lot of folks use it. It doesn't have a lot of support in formal trials suggesting that it's effective, but it does have an advantage in that it also is a reasonably good treatment for insomnia. It is a medicine that can work as an antidepressant adjunctive agent, so it can be added to an antidepressant and help with that. So it has some benefits outside of the psychosis benefits that haven't, frankly, been shown to pan out in trials. In terms of anxiety, so I mentioned benzodiazepines before as a risk factor for developing hallucinations, but sometimes we have to use them because someone is so anxious that it's disabling. But the serotonin reuptake agents, your sertraline or Zoloft, Lexapro or escitalopram, medicines in that category probably work to treat anxiety. Buspirone, which is kind of an atypical serotonin agent, works. There's a medicine called mirtazapine or Remeron. That's an antidepressant that also can be an effective anti-anxiety agent.
Do the antidepressants ever cause hallucinations, or no link?
So I would say almost certainly there's someone out there who's had hallucinations with starting an antidepressant medication. Is that common? I would say probably not. I've had a number of folks who started having hallucinations, and we adjusted their medications in various ways, including withdrawing antidepressant medications, and I've never been convinced that there was a significant effect.
Okay. So you mentioned Nuplazid. Somebody asked the question, is it contraindicated if you have AFib? Do you know anything about that?
It is not contraindicated if you have AFib. Like other medicines in the antipsychotic category, and in fact antidepressants, it can make some changes in heart rhythm, but not the kind that are likely to provoke a problem with AFib or make AFib emerge if someone's got their AFib under control.
Okay, great. Let's see. You're answering so many of them. When should people with Parkinson's come in to see you?
Right now.
Yeah, they're having hallucinations. Like at what point? Because I think that's a lot of question. They don't know what to do. They're feeling this, and the person their care partner is worried. When do you suggest they come in?
So the temptation is to say, well, if it's not bothering you, just let it ride until it bothers you. However, even if you're not going to get an antipsychotic medication, the hallucinations could be caused by something else that needs to be tuned up. So you have these potential medical problems, dehydration, even constipation, sleep deprivation. So there are numerous things that need to be evaluated to see why hallucinations might have emerged. Now, you may come to the conclusion in that appointment and say, listen, everything's pretty square as far as we can tell. And I don't think this is bad enough that I want to add an antipsychotic medication. But that conclusion isn't always the way that these appointments end. Sometimes we can find that, yeah, there's something that's provoking this, and it's something that has the potential to cause other problems down the road. So we address it. So the hallucinations can be an indication that something needs to be taken care of, and that may be causing hallucinations as a secondary effect.
Right. And so that's a good point, because it tends to be the case a lot of times when people have Parkinson's, everything that goes wrong, they think is the Parkinson's.
Mm-hmm.
But if they come in and you're like, well, I don't think that's it. This is something else that you have. That's why it's so critical, right? It could be something unrelated to Parkinson's. So.
Yeah, and it can be very frustrating for patients. Unfortunately, my tremor is getting worse. It suddenly got worse over the past 2 days. I need to talk to my Parkinson's doctor. And we reply with, well, Parkinson's doesn't typically work that way, where things suddenly get worse. It's a slowly progressive disease. When we see things suddenly get worse, what we're seeing is more likely the Parkinson's symptoms being exacerbated by something going wrong in your body generally. So, I hate giving that answer to patients because it's kind of unsatisfactory, right? Hey, my Parkinson's symptoms are worse. And your Parkinson's doctor says, well, that's not my area. So we try and be as helpful as we can in helping folks to understand that and realize, and we also pay attention to the fact that we don't just drop it at that point, right? We call back in 2 or 3 days. We find out, hey, were you able to get the urinalysis? Did you get a chest x-ray? How are you feeling physically? Your symptoms are still there. Do you feel like okay, at this point, maybe we do need to do something with your medicines?
Right, which is also why communicating with their full care team, their primary care doctor, whoever else that they do see, is so important, so that you're going to keep that continuity of care.
Absolutely.
Let's see. I think you already answered this. I just want to call it out because the person did ask a very specific question about the distinction between YOPD versus older onset of Parkinson's and the susceptibility of hallucinations. And yes, because the older you are, the more likely you are to have hallucinations. Also, YOPD people tend to be more predominant non-motor for a longer time than motor symptoms, and motor symptoms seems to be a piece of that. Is that correct?
Yes, but there's also the contravening factor that let's say at 70 years old, right? You have someone with typical onset Parkinson's and someone with young onset Parkinson's. Who has had the disease for longer? The young onset Parkinson's person does. So that actually works against some of the other issues. And then in terms of the non-motor symptoms, although people with young onset Parkinson's do have higher rates of non-motor symptoms, don't take that to mean that they have fewer motor symptoms. They just have additional stuff on top of the motor symptoms, and their motor symptoms tend to have, the non-tremor predominant form, which does predispose you to more sort of cognitive and emotional and autonomic system problems compared to the more typical and older onset tremor predominant Parkinson's.
Great. Let's see. I'm going to go to the chat.
Yeah. So I see a couple of questions there that I can just go ahead and take. So what percentage of people with Nuplazid have a paradoxical effect that their hallucinations and delusions get worse? It seems to be about 2 or 3%. In my experience, is probably less than that, but it seemed to be 2 or 3% in the pre-marketing studies. And that was about the same as placebo. So it's not clear whether what we're seeing there is that pimavansarin actually makes the hallucinations and delusions worse versus it's just not helping in some people in the same way placebo is just not helping in some people.
Okay.
And there's a question about rivastigmine. I'm glad that someone brought up rivastigmine. So this is one of the acetylcholinesterase inhibitors. Raises levels of acetylcholine in the brain. People with hallucinations in Parkinson's disease and people with cognitive trouble in Parkinson's disease have lower levels of acetylcholine. And this person asks, does this cholinesterase inhibitor rivastigmine work for a year and then not so much? I definitely see the effects of cholinesterase inhibitors, quote unquote, wearing off. Probably what's happening, this at least is the going theory, is not that the medicine stops working, but that the brain has gotten to a point where there's so little acetylcholine that raising the levels no longer works in controlling the symptoms. So, you know, it's sort of like if you have a headache that responds to 200 milligrams of ibuprofen, and that headache just keeps getting worse and worse, at some point 200 milligrams isn't going to cut it. It's not because 200 milligrams has changed or stopped doing what it did. It's that now the condition has outstripped the ability of that dose of medication to work.
Let's see. Right, Ambrisia, and the hallucinations seem to get worse almost immediately. Is this typical? Do you have much experience with that, Ambrisia, the inhaler?
I think I've seen one patient with that who did not have hallucinations. It does make some sense because anything that increases dopamine availability has the potential to increase hallucinations. So not terribly surprising to hear that about Ambrisia.
Okay. Are there any other questions?
There was a question about how common it is in Parkinson's disease, I think. So people can have hallucinations even as their first symptom of Parkinson's disease. That's admittedly rare, but it happens. Eventually, about 75% of people with Parkinson's disease will have had a hallucination at some time or the other. I think the figures are that for 3 years of Parkinson's disease, about 10% of folks will have had hallucinations or delusions. And then at 5 years of Parkinson's disease, it's somewhere close to 50%, like 35 to 50%.
Okay. I don't think you answered this yet. When people have hallucinations or delusions, do people tend to have both of them, or do they tend to be one more than the other?
Hallucinations are far more common than, well, I shouldn't say far more common. Hallucinations are substantially more common than delusions. It's relatively unusual to have delusions without hallucinations, but a fair number of people have hallucinations and no delusions.
Okay, that's great. Let's see. I'm not sure what the
does rivastigmine cause hallucinations? So the way to think about this is that anything that affects brain function in folks with Parkinson's disease has the potential to cause hallucinations in a given individual. Just like people have weird individual side effects to any medication. The general thought on rivastigmine and the other cholinesterase inhibitors, galantamine and donepezil, is that, you know, if you take 100 people with hallucinations, the ones who take one of those medications are going to be less likely to have hallucinations. However, there are going to be some people in there who are going to have a side effect, and that side effect may be hallucinations. So in general, I would say if you're not taking rivastigmine and that's been proposed to you, either for hallucinations or for cognitive dysfunction or something else, in general, it's probably a good idea to go ahead with the rivastigmine. The other type of cognitive medication that's out there, so these cholinesterase inhibitors, rivastigmine and the others, are used to treat cognitive dysfunction, and they happen to have a benefit for hallucinations as well. The other cognitive medicine that's available is called memantine, or Namenda is the brand name. It was really developed to be used in conjunction with cholinesterase inhibitors. So it's a reasonable thing to combine memantine and the cholinesterase inhibitors. We would not expect memantine to have much effect on hallucinations. There are many reports at this point of memantine inducing hallucinations in people with Alzheimer's disease. But again, it's rare, it's not common. but you should not poo-poo the idea that if you start taking memantine and have hallucinations, that it may be a contributor.
Okay. Let's see. When my person with Parkinson's is hallucinating, is it best to tell them it isn't real, or should I play along?
I think sort of in between. Recognize that it is real to them. So behave as if whatever they're seeing, whatever they're hearing, is actually happening for them. If someone is seeing a stranger in their home, that can be very disturbing. You can't really say, just ignore it. They're not there. The person is there for them. So you say, well, you ask, what does he seem to be doing? Do you want me to go over and do something? I can't see him, but maybe you can sort of show me where he is. Why don't you come over here with me? So don't simply say, ignore it, it's not there, unless that's what the person asks you. Sometimes folks with PD will tell me that, oh, I can tell when it's not real. I'll just ask my wife, and she tells me, and then everything's okay. But if someone is convinced that it's real, trying to convince them that it's not without concrete evidence doesn't make much sense. I mean, from the time we learn to understand words and talk, people are saying, don't believe something unless you see it. I'll believe it when I see it with my own eyes.
Right.
Show me and I'll believe you. We are programmed to believe what we see. In the absence of other data, so reaching out and touching this hallucination, seeing there's nothing there. In the absence of other data, we're going to believe what we see. So you don't have to agree, oh yeah, I see him too, but you have to recognize that it is real for them. Someone also asked about reduplicative paramnesia. So that's where someone believes that a place that they're in is actually not that place, but a very clever duplicate. Exactly the same, but I just know it's not. And this also happens, it's a syndrome called Capgras syndrome with people. So you look just like my wife. In fact, you have the same name, but you're not my wife. That's a tough one. I consider that to be among the psychotic phenomena. It is a delusional symptom, and antipsychotic medications or doing the same things that we would do when we see other delusions might be helpful for that.
What do you do in that situation?
Yeah.
No, they're just saying, hey, no, I need to go to our house.
Yeah. So I had one caregiver, and I can't say that I've seen a really great solution to a lot of times to this, but one caregiver who actually got in the car with the patient, drove, and then would eventually wind up at the street, and they'd say, okay, tell me which one is the right one. And sometimes the patient would say it's that one. Sometimes they'd say, no, this is the wrong street. They'd go circle around and come back to the same street again until he felt that this was the right house. Not everybody has the time to do that. Not everybody has the ability to drive around either. I think reassurance and perhaps redirection are the best things. One other technique that a caregiver used was asking the person, well, what would be in your house that could not be in a fake house? Mm-hmm. And if they're able to come up with something and you can go and find that thing, often that will at least put things on pause for a little bit in terms of the paramnesia. That's
a great strategy. What about exercise? Does exercise have any relation to hallucination? Do they tend to bring them on? Does it quell them?
There's a general sense that exercise reduces the likelihood of hallucinations, whether it's a direct effect of the cardiovascular flow or whether it's more related to the fact that you're doing something, because hallucinations tend to occur more when the mind is not occupied with other things. So they tend to occur in quiescent periods when someone's just sitting there not really thinking about something. These stimuli come in, they don't get suppressed, and there they are. So I would say exercise is typically good, and all kinds of activity tend to be good, as long as they're not passive. So watching television can actually produce hallucinations or delusions in some people because it's passive. There's information coming in, and fundamentally, hallucinations and delusions are a failure of the brain's ability to connect stimuli with reality or unreality, reality testing. So if you have stimuli coming in from your own brain or from a television or anything else that's passive and your reality testing system is off, you may incorporate those images into your own life.
Somebody once told me that the person was watching TV and they found that they were getting a lot of hallucinations, but the person was only watched TV at night. And so we said, oh, turn the lights on. Maybe, all the shadows that are created from the TV and the light projecting different places could be something that did it. And they turned the lights on, so it was like a really bright day. And that actually helped. So little things like shadows and light, I think, can be really helpful for people that are experiencing hallucinations and stuff like that.
Yeah, there is a sense, and I think there's more about this in the Alzheimer literature than the Parkinson literature, but the less ambiguous you make the sensory input, the less likely people are to have hallucinations. Because we've all had the illusion of, looking around and, a coat rack or a shirt on a hanger, and it looks like a person when we first look at it. And then our reality testing kicks in and says, no, that's not what that is. Well, that is much less likely to happen in a bright room than in a dark room. So these challenges to our reality testing system are less likely to happen when you have unambiguous external stimuli.
Great. Well, that's a really easy thing people can do. So if that's happening, definitely work on lighting and mirrors and stuff like that can be messing with your mind a little bit. How about, let me see. A similar secret sign to identify what was real. Oh, that was capgrass. We had talked about that. When will this be available on YouTube? Person with Parkinson's is in PT now. Yes, I will make sure that you get this recording, everybody. Don't worry about that. We'll send it to you. Anybody who is on here now will get the recording for sure. Let's see. Have you ever used niacin or other vitamin B supplements to decrease hallucinations?
I have used B supplementation in people who were vitamin B deficient. I've not used it as treatment in people who didn't have vitamin B deficiencies. I don't know of data surrounding that, so I'm not going to sort of say one way or the other. However, vitamin B, particularly vitamin B12, is one of the things that we check for when people develop hallucinations that are either atypically early in Parkinson's disease or that seem to come on more rapidly. Someone's flagrantly hallucinating and delusional when last week they had nothing going on or they were just having passage hallucinations.
Okay, great. Let's see, anything else? For those of you, if it seems like I haven't asked your question, it's because I believe the answer was already given during the time. Maybe you showed up late or whatever, but you'll be able to get the answer when you see the recording.
Oh, sorry, I was just going to ask, did I make clear the difference between delusions and hallucinations?
Yeah, you can do that. Yes. You can do that if you want to do that. Yeah.
Okay. So a hallucination is an abnormal sensory experience in the absence of an external stimulus. So in other words, your brain creates a sensation, a visual sensation or an auditory sensation or an olfactory sensation, a smell, or a tactile sensation, a touch. A delusion is a fixed false belief. So it's that someone thinks something is true when all evidence suggests or sometimes clearly shows that it is not true. So the difference is one is a sensory experience, the other is a thought experience.
Great. I think we sort of addressed the advanced psychosis and sort of looking at it gets worse as your Parkinson's progresses, sometimes because your medications are increased as your Parkinson's progresses. Let's see. My husband has had hallucinations for 10 years. I give him a B12 shot monthly. What is the optimal dose that may help hallucinations? I don't know that Dr. Wint could answer that just because
I don't have data on that.
Doesn't have data, also doesn't know your husband well, but are you doing the B12 shot for the hallucinations in particular? And is that just not working, or it used to work and it doesn't work anymore? But I would definitely talk to your personal doctor about that. Any other questions? Dr. Wint is here, ready to answer.
I see a question that came up. Is there such a thing as advanced psychosis? I guess I've never really heard that particular term. I assume it just means severe psychosis. And are there ways to distinguish end-stage Parkinson's from complications due to medication or other issues? Really, the only way to be sure of that is to check into the other health issues and try and make some adjustments with the medications. It can be difficult to tell the difference. You know, there are times when it's obvious. I start a medication today, Friday or Saturday, the patient is starting to have some kind of new problem. But unfortunately, most of the time, it's not that clear. And secondly, because Parkinson's disease is constantly, relentlessly progressing in terms of its effects on the brain, things that are fine today, like a certain dose of pramipexole, may a month from now not be. So while you might say, well, he's been on pramipexole for 2 years, that can't be what's causing the hallucinations. Well, it may not be what's causing the hallucinations, but the brain is in a state now where the pramipexole helps to exacerbate the likelihood of hallucinations.
Yeah, that's great to know. This is an interesting question. Can you have hallucinations and still be mentally okay?
That is a great question. Actually, you can have both hallucinations and delusions and be, quote, mentally okay. By this, I think the person may be asking, does a hallucination or delusion mean that I am psychotic? And I try to refer to these as psychosis symptoms, because being psychotic, yes, hallucinations and delusions are a part of the overall picture of a psychotic disorder. However, people who are quote unquote psychotic, like those with schizophrenia or psychotic mood disorders, also have problems with the way that they organize their thoughts. They also have disorganized behavior, meaning doing very strange things for unclear reasons. And they tend to have very little insight into what's going on. In Parkinson's disease, very often the hallucinations and delusions are relatively circumscribed. The delusion is not sort of the guiding principle for that person's life, whereas often in schizophrenia, it is. The hallucinations will often not necessarily link up with the delusions in any way. So someone could be seeing cats and also have a paranoid delusion, and there's no relationship between the two, whereas in things like schizophrenia, they tend to come as a whole. So I try to tell my patients that having hallucinations and delusions, yes, those are psychosis symptoms. It does not mean that you have a psychotic illness. It does not mean that the rest of your brain is not working well in a holistic way, the way that we see in schizophrenia. It's like if someone comes to me and says, I have a fever, I don't automatically say you must have COVID or even that you must have an infection. Mm-hmm. Fever is one symptom of these things, and it could mean that. But in your particular case, you know, where I know you're not coughing, you're not having trouble breathing, no, I'm going to think that fever might be a urinary tract infection.
Great. How sizable is the risk of people with Parkinson's who are hallucinating, delusional, being led to attempt serious self-harm as a result?
That's a great question. So this seems to be actually pretty rare in Parkinson's disease. And I would also throw in there that also people with depression and Parkinson's disease tend to have much lower rates of suicidal thoughts and suicidal attempts than people with depression outside of Parkinson's disease, let's say. So this tends to be much more damaging sort of to relationships and to quality of life and just overall contentment and happiness than it is likely to cause some kind of physical harm to either the person or even someone that they might be delusional about.
It sounds like hallucinations and delusions interfere with executive function. Is that so?
I might think of it the other way. So for those unfamiliar with the terminology, executive function is the process by which your brain decides how to allocate its resources on a moment by moment basis. So the same way an executive for a company decides what the overall goal of that company will be, the little things you need to do to accomplish those goals, which of those little things is important right now versus next year. Your brain's constantly doing these things. I think executive function or a decline in executive function may contribute to the likelihood of having hallucinations and delusions, because one of the executive functions actually is reality testing, looking at a stimulus and deciding the extent to which it means something significant, and also the extent to which it should drive your decisions and your behavior. So yes, impaired executive function and psychosis symptoms do go together, but I think it's more likely that impaired executive function drives psychosis symptoms.
Okay. Let's see. Somebody says, excellent presentation. Thank you. Sometimes after 15 years, it is the same old stuff. That's great. Let's see. I was told I don't. Okay. I think that's a question sort of unrelated to Parkinson's psychosis, but she says she's 75 years old. Is it okay to take meds? I'm sorry. Is it okay to take meds? Is that too old? She has a lot of other issues. I think that's
to take Parkinson's medicines, or
I'm sorry, I'm having a hard time understanding that.
Oh, I think I'm figuring out. So right now, this person has head tremor, but not much else going on, and the doctor advised not to take medications until things get worse. And he has a lot of other problems. So, sort of, should he take medications? Is it okay to hold off on taking medicines? So, medicines in Parkinson's disease remain symptomatic, meaning that taking medicine now or later does not change what happens with the overall disease course. The medicines are intended to help you feel and function better. If right now you are not suffering from significant disability or embarrassment or whatever due to your Parkinson's symptoms, and you are concerned about taking medications, then in general, I would say that it's okay to hold off on medications. It's not going to make you get worse not taking medications. I've had a lot of people come in, yeah, I was diagnosed with Parkinson's 3 years ago. I decided not to take medications, and now it's worse. I guess I made the wrong decision. No, you did not. If taking medications at that time was not suitable for you, and now it is, that doesn't mean it was a wrong decision at that time. It's just a different stage of the disease, a different portion of your life, and your not taking medications did not cause anything to get worse.
Great. Okay, let's take this last question. Well, they're kind of both. Can one take surround? I'm not sure what you mean by that, surround and Nuplazid at the same time. And I don't know what surround is supposed to be. I'm guessing there was an autocorrect that did that. Maybe if you want to type in what you were saying first, that'd be great. And is Nuplazid safe? I've seen some news reports about adverse effects. And
yeah,
you can address that a little bit.
Yeah, pimavansarin or Nuplazid is a lot safer than other antipsychotic medications. So I mentioned that the most common side effect that was greater than placebo, it was swelling of the legs. So that occurred in about 8% of people. With placebo is about 3%. Are there side effects? Absolutely. Any medicine that has an effect can have a side effect. The most common side effects that were seen in the study, the pivotal study, were urinary tract infections and falls. But both of those occurred just slightly more commonly than placebo. So it's not at all clear that pimavansarin was the cause of them. Yeah. Nevertheless, if you start a medicine and you see problems with it, or you see problems, within days of starting that, you definitely want to suspect that medicine. Number two, there is no brain on earth. There has never been on earth a brain that's identical to yours. There never will be on earth a brain that's identical to yours, even if you have an identical twin. And so you can have problems with a brain medicine that nobody else on earth has ever had. That being said, the likelihood of that happening with pimavansarin appears to be quite low. So pimavansarin, because it's in the general category of antipsychotic medications, they've had to do a lot of monitoring after it went to the market to make sure that what they thought they saw in the pre-marketing studies in terms of the likelihood of side effects really matches with real life experience. My understanding is that to this point, it really does seem to match up pretty well. So yes, there were some people with side effects. No, most people did not have.
Yeah, and I think one of the issues they unfortunately had was that the news stories got very crazy and really scared people about what it was. And they, you know, that information, you know, you're always looking for news. You always have to look and say, like, what's the whole picture?
Right.
And who are those people that they were talking about? Well, they were very, very advanced Parkinson's.
Yes.
So that's something to consider. And always, if you have a question about something, you see something in the news and it worries you, or you think, oh gosh, I'll never be able to do that, you know, look up the actual research itself. Don't just sort of count on your news outlet to tell you what it is, right? We know that they're always trying to get us to click through on different things. Look for the research, talk to your doctor, and you know, get all the information that you really need to make the best decision for you. And again, like Dr. Wint said, there, you know, you can try something, and if it doesn't work, you can try something else, and you can go off that medicine. And there's a lot of things that can be done. There's a lot of Parkinson's medications that can be used to kind of address your very unique situation. So thank you. We're almost at the top of the hour. I really appreciate you being here with us today, Dr. Wint. It was great.
Sure.
And I know everybody else is very appreciative of it. So we will make sure to have this recording for everybody. We'll send it out to you either later this week or early next week. And as always, if you have questions, feel free to reach out to me at blog@dpf.org. Thank you all for coming, and hope to see you soon on another webinar.
Thank you.
Thank you.